So it's my pleasure to introduce next Katherine Heller. She is both in, I suppose, the unreal world of academics, but the real world of Google all at the same time. I suspect a life goal of hers was never to be 1K on United, but Duke is on one side and Google's on the other, so if she's not there yet, she'll get there soon. And again, we're going to stay practical. Last talk was practical at a world level. I'm assuming we're staying practical at the US level here? More or less. All right. Katherine, take it away.
Thanks very much. Yeah, so I'm talking about machine learning for healthcare and practice, and by I'm talking about, I mean I'm going to give you a 10-minute introduction, and then I'm going to let the people who I collaborate with, my clinical collaborators, talk about each of the projects that I've worked on at Duke University and how they're going in terms of deployment. Oh, and I forgot my slide advancing thing. Okay. So basically this talk is about collaboration, and it's about collaboration mostly between quantitative researchers and clinicians, but it's also about valuing teams of people working on things to get things from the level of like a concept in order to get things from the level of being a concept within machine learning in terms of what you can do in the field of healthcare to being deployed at a hospital or in a healthcare setting. And these collaborations involve large teams of people. And those people have all kinds of knowledge, right? So it can be medical knowledge, it can be all kinds of medical knowledge. So you might need a whole team of specialists that you're speaking to. It can be computational knowledge, right? So you might need somebody who does machine learning research. You might need people who do other kinds of data science in order to translate that to deployment. It might be IT or it might be infrastructure. And you'll be hearing from a lot of different people who've worked on different parts of deployment of, in particular, sepsis. So these teams are really necessary to successfully build and deploy machine learning systems in hospitals or in healthcare in general. So one of the things that I've worked on is dealing with what happens when a patient is outside the hospital, right? So for all of the people who have chronic diseases, most of their lives are lived not in a clinical setting. How do you start collecting data on people in that situation? How can you make decisions to make people's lives better when they're not in the hospital or admitted on an inpatient basis? And so there are a whole bunch of things that I've noticed as I've gone through trying to work on these teams or working in collaboration with whole groups of people. And one is the idea of devaluing other people's areas of expertise, because this happens a lot, right? Everybody is very prone to thinking that the thing that they do is really awesome. But if you go into a collaboration thinking that you're way above like everybody else you're talking to, your collaboration isn't going to go very far, and other people are going to get resentful. So somehow thinking that your own field is inherently superior is probably not helpful. Okay, so there have been a bunch of hurdles that we've come across trying to do machine learning for healthcare, and I'll talk a little bit about some of them here. So first I'll talk about hospitals. There are drawbacks to every place. I'm just choosing to start with hospitals. So hospitals are large bureaucratic organizations, and their main job is to provide care for patients. And so the thing that they value, or the thing that I've seen them really value, are day-to-day operations, right? A patient comes in, they're sick, they want to make them better right now. They're interested in doing the same thing today that they did yesterday, and they are almost too busy to consider innovation often. So they see change as a potential liability. What happens if we have a patient and we don't make them better and we could have, right? Whereas I see change as something that can really improve your ability to do healthcare. Business is at the top, right? So when you talk to hospital leadership, you often have a group of people who are really concerned about cost, and that's probably regardless of what country you're in. So we've had this happen. A clinician might be very happy with the kind of innovation you're presenting, but the hospital leadership isn't seeing the cost savings, so they're like, I don't really care enough. That's really disheartening. Anyway, So there are also places that really value medical doctors. And so PhDs are often seen as people who kind of like do power calculations or something like that. And so at Duke, even the IT department is largely run by MDs, which is very questionable to me at best. Okay, so another experience I've had is the experience of working on an app, and I'm thinking largely on an app for the purpose of trying to collect data about people outside of a hospital or clinic environment. And this presents its own set of challenges. So one of the challenges we've had is that apps are incredibly expensive. Of all the research that I've done, of all of the projects that I've had, this is probably my most expensive, not probably, it is certainly my most expensive project. And so where does the money come from? And that's a really tough question. And it's hard to get grants, so often federal agencies don't really consider the development of apps research. So like the data analysis might be research, but the development of the app itself, and the data analysis costs very little in comparison, but the development of the app itself is not really research, so they don't want to pay for it. And so even if you are doing something like you're getting a grant for the analysis, the machine learning analysis of the data coming out, it's hard to get money for the actual development of the thing whose data you're analyzing. Okay, so apps also have, there's a lot of moving parts in these projects, right? So you need to contract out with a lot of people or work with a lot of people, right? So there's like front-end development of the app, there's back-end development of the app. There are questions like, where is your data getting stored? None of these questions are potentially really new, right? Like, it's got to be HIPAA compliant. What's HIPAA compliant? What's HIPAA compliant? Varies institution to institution. There are a whole bunch of problems, and you need to face every single one of them if you want to get data out that's reasonable. Okay, so things are really, really new in this setting. I'm really excited, actually, about this setting. I think that this setting is going to make a huge amount of difference in the lives of people and the healthcare of people in general once we can start collecting data on them. But it's not there yet, and it's kind of scary, which I'll get to. Okay, so collaboration in academia or in tech industry. So these are kind of, in some ways, polar opposites, right? So if you're talking about an academic hospital setting, you're talking about a setting that really values medical doctors, and they don't really quite know what to make of PhDs. And when you're talking about the tech industry, you're talking about a company of people who really value PhDs, and they don't know quite what to make of medical doctors. So if you talk to a hospital will often be like, I don't understand exactly what quantitative people do, or more often they think they know and they really don't. And if you ask a tech company, tech companies are confused about what clinicians do sometimes. Like, one of the things I've heard in tech companies is like, we have a doctor. And I'm like, okay, that's great. I just came from a hospital of 3,000 doctors, and like they're like pathologists or pediatricians or something. And that kind of concept is I think not always as present as it should be. Hospitals, where the computational resources coming from, that's something that they often don't know, right? These are not institutions that are set up to have a large swath of computational resources, whereas tech companies are. They don't have a problem with computational resources, but where is the access to patients or even providers coming from, right? They have to work with a hospital in order to get access to any of these. And everyone, regardless of whether you're an academic hospital or a tech industry or a tech company, is very concerned about getting sued or their public perception. And so it's not clear to anyone how people should be innovating, because to do something like I'm talking about, to improve the lives of people who are, say, living with a chronic disease at home, you have to be collecting data about people at home. And once you're talking about doing that, you're talking about everybody freaking out about the privacy of their data. And so it leaves a lot of open questions about where can we make progress versus like, where, is the New York Times going to get a hold of it and write you on the front page and say that you're really bad? Okay. The last thing I wanted to kind of sneak in there was dealing with people and emotions. And this is kind of like broadly, I would say broadly a theme in this area of work, and actually in other areas. I do a lot of work for diversity and inclusion, and it's kind of an issue there also, right? So being able to deal with other people and the idea that other people have emotions sometimes is something that quantitative people in particular are not always really good at. And like the number of times actually I've had somebody in a quantitative field come up to me and be like, but you're expecting me to deal with that person's emotion. That's a burden. And it's like, yeah, that is a burden, I guess. But being able to deal with people and the fact that people have emotions is something that's really going to be beneficial to your collaboration. And it's really going to benefit you in life in general. I would say that this is like competency, right? Like this is part of being a competent person. And you're all laughing, but like our previous speaker was just up here and was talking about villages where the women die and it falls apart and children starve, right? Because like, I don't know, the guys can't get it together or something like that, right? Right? Like men are competent people too. And I think that we have to start expecting from the world in general, from a diverse set of people, that they act like the competent people that they are. And so understanding people from a variety of backgrounds is really important for functioning in a more diverse world. Okay, so the outline of this talk. So first, Mark is going to talk about sepsis with a whole bunch of other people, and I will let them introduce themselves one at a time. They're going to talk about the sepsis deployment at Duke University. Kristen is going to talk about surgery, and Lee is going to talk about our multiple sclerosis app. I will very, very quickly remind you that there is machine learning methodology behind these. So for sepsis, there was a Gaussian process combined with a recurrent neural net framework that we had a paper on at ICML and at MLHC in 2017. And it's really cool. And there was a whole bunch of related work, actually even presented at this meeting, coming off of that. And this is what you're going to see implemented in the sepsis detection stuff at Duke. There is also work by my former, that was by my former student, Joe Futoma. There was also very interesting methodological work done in surgery by my former student, Liz Lorenzi, having to do with hierarchical infinite latent factor models and about clustering CPT codes. We didn't actually deploy any of this. What we deployed is a sparse logistic regression kind of pipeline for predicting whether or not somebody has surgical complications, and Kristen will talk about that. And lastly, Lee will talk about the MS app that we've developed, and the master students tried a whole bunch of methodological things that are much less sophisticated, including like logistic regression and some basic clustering methods, et cetera. And hopefully there will be more new cool methodology coming out of that. Okay, so this is my last slide. I just wanted to say thank you to everybody. It's been a real pleasure working with all of you, and it's just been great. And so everybody, hopefully everybody is up there. You can see the sepsis team, the MS team, and the surgery team. There are a whole bunch of people, and they have a whole bunch of roles, data science roles, clinician roles, and everything in between. And now I will let them talk. Thanks.
So thank you to Katherine for letting us kind of take some of this time and walk you through how we've built an ecosystem for integrating machine learning into healthcare at Duke. So I'm going to give you a quick overview of our team. We're going to kind of talk about some principles that we use, which are listed out here: build to show value, build to integrate, and then from models to bedside, build to scale. We're going to talk about use cases in surgery and then go deep into Sepsis Watch, which is our application name. So we are DHI, the Duke Institute for Health Innovation. We have a large team here at this meeting, many students, many full-time staff. You're actually seeing about more than half the team here. So there's a handful of people holding down the fort in Durham. So our mission is to catalyze innovation at Duke. We want to transform health and healthcare, and our approach is by design. We work directly with frontline staff to design new workflows and care models. We have two mechanisms by which we source innovations that we work on. The one on the right, we're not going to touch on much today, or my right, yeah, you're right too, which is more of a Shark Tank competition, and then the one on the left is a top-down, bottom-up approach. And this is the mechanism by which both projects we're going to talk about today were identified from frontline staff. One was around high rates of surgical complications, the other was around poor compliance with sepsis treatment and poor sepsis detection. So when we try to describe what we do in healthcare, it's a concept from economics. It's called a production possibility frontier. So large organizations are typically fixed in their capacity to produce goods. So kind of adopting that for healthcare, you can think about there's a fixed amount of goods that we can produce in terms of low-cost services and high-quality services, and that there would be a trade-off if we wanted to move along that curve. What our team tries to do is try to think about, okay, there's other ways in which we can generate goods and services in healthcare, and there doesn't have to be that trade-off. How do we both develop more low-cost services and high-quality services? So we've grown a lot over the years. I first joined the team in 2014 when we weren't yet doing much in data science, and I'm going to kind of walk us through what the last 5 years have looked like. So in year one, it was just me as a full-time staff starting student programs, and then we had one data science project that was ultimately integrated into operations around chronic kidney disease. This was my first collaboration with Joe and with Katherine. We had 3 in total, 1 startup that was created. Go forward to 2016, we grow a little bit in terms of a team. We're doing double the amount of projects. From that time period, the sepsis project, which we're going to talk a lot about, as well as continued partnership with our accountable care organization in Durham. The next year grew a little bit more as a team. We're going to talk a lot about the investment that happened starting at this period, and then more integrations into operations. One of these was integrated as a best practice advisory in the electronic health record. Kristen's going to talk about the perioperative optimization, and then Palyalytics was a project that Michael led that was also in partnership with our accountable care organization. So doing integrations both inpatient in the hospital and outpatient for population health management. We get to 2018, now we're looking at 12 projects. Things are growing quickly, still growing the team relatively slowly. And then we're only 4 months into 2019 and already have more than 10 projects that we're actively working on. And what I highlight here is we're doing our first model update. So we've talked a lot about the sepsis model that was developed, but now we're trying to optimize it for other care settings within our hospital. The way that we have grown, obviously, has not been by growing the team at scale. So there's been other types of principles that we've had to adopt as a team. One is build to show value, build to integrate, build to scale. And throughout this, we also try to build responsibly. So what I mean by that, I'm just going to call out a few things. Here's more of the things that we do, but just a handful. One is model monitoring. So when you enter our office in Durham, it's actually Marshall's office. We have a 55-inch monitor that shows you the current state of the triage page of the sepsis application on the left-hand side. And on the right-hand side, you see the model output. So we have mean, standard deviation, median, number of risk scores being calculated across 3 hospitals. And then the other example is model fact sheets. So how do we distill information that we present to clinical end users so that they are aware of both what the model is doing and how it should be used in clinical practice? So I'm going to hand off to Kristen, who's going to talk about surgery use cases.
Hi, I'm Kristen, and I'm going to briefly describe our surgical projects that we developed from our data asset called Pythia through the lens of DHI's guiding principles, building to show value, building to integrate, and then building to scale. So overall, building to show value is working on the right project with the right team. Building to integrate is designing solutions together, establishing governance, driving adoption, collaboration to train and and integrate into clinical workflows. And then lastly, building to scale, so developing the infrastructure to support other projects and not just your project that you're starting out with. So starting out by the first principle, building to show value. So with this set of surgical data projects, we identified this problem. There are around 50 million surgical procedures that are performed each year across the United States, and 30% of those patients undergoing those procedures experience a set of complications, which include anywhere from death to infection, hemorrhage, clotting, you name it. So pretty much the toll on this, on our patients, on our society, and our healthcare system is pretty enormous. Oh, wrong way. So wanting to delve further into this problem, we partnered with an interdisciplinary team of physicians who had started POSH Clinic at our healthcare system. So POSH Clinic stands for the Perioperative Optimization of Senior Health. And basically what they do in this clinic is that they identify high-risk patients, patients who are older, patients who have severe comorbidities, and they try and tune them up for surgeries in an effort to optimize chronic conditions before the stress of anesthesia, mechanical ventilation, and then complex surgical procedures. So trying to minimize post-op complications prior to the procedure takes place. And this is an example of the perioperative journey. They would be identified by physicians, usually surgeons, I guess directed to this clinic before surgery, and then hopefully not experience any complications. So working with the right team on this problem, we developed a set of post-operative complication risk prediction models for patients undergoing invasive procedures, and we published this work last year. So one of the biggest problems this clinical team was facing was they were having issues distinguishing those at the highest risk of experiencing complications, and then prioritizing those patients in particular for clinic efficiency purposes. So what we are able to do is predict that risk, stratify those patients within a high-risk group, and this task without any support is super challenging just due to the interplay of multiple demographic and medical conditions. So machine learning is perfectly set to handle this task through identifying optimal thresholds. And in order to accomplish this, we worked with the team, our clinical team, to identify the optimal threshold, where that threshold should be placed for their specific workflow. So we developed an app for the clinicians in POSH Clinic as a decision support tool. And I think this project was super successful because the problem and the design was, the solution was designed around the clinical question. So one, something that was a problem that was best answered using machine learning. Two, it had a clear implementation workflow within an existing clinic. And three, the model output, this app prompted specific clinical interventions by providers for patients. But most importantly, that working with this team gave us access to the expansive network through our healthcare system. So the data that we developed to train these models was stored on an open science data platform for the university. It housed 227 clinically curated features for around 500,000 patients. And this caught the eye of the Department of Surgery, more specifically the chairman of the department, Dr. Alan Kirk, which started our team's formal relationship with him and the department. So this department, also quite large, is able to support its own research organizations, including Duke SCORES, which is a surgical center for outcomes research group, and then the Laboratory for Transformative Administration, another large training research group. So by opening up our work and our data and partnering with these large organizations, we're able to support their projects as well as our own, and also grow relationships in our networks. these relationships, these types of relationships, work to build trust between physician scientists and data science technology, and I think allowing for the ability to further advance machine learning in healthcare with the right partnerships. So thinking beyond the single implementation of POSH, our models within POSH, we plan to implement across our healthcare system. And that was how the Federated Modelling, which I presented earlier this afternoon, was born. So our healthcare system is made up of 3 hospitals that serve 3 distinct populations. So different training combinations or ensembling combinations, which is what we ended up trying, becomes important when trying to optimize models' performance for a specific location. So DHI has developed an automated EHR data pipeline, which will be discussed in detail later in this talk, but it houses meaningful curated data solely for the purpose of data science research. Pythia, the data that was used for our surgical models, is now integrated into that pipeline, which now represents all of the patients within our healthcare system. So furthermore, this pipeline is opened up to Duke investigators, trainees, and administrators for research purposes. So once the pipeline was deployed, one of the first questions we had was, how can we demonstrate quality of the data from this pipeline to its end users? And we started off by just simply calculating variable missingness among this EHR pipeline, and then quickly found this complex framework, data quality framework, which we applied and then also adapted to test the data quality of our data pipeline. This framework was originally developed by PCORNet, which is the Patient-Centered Research Outcomes, or Patient-Centered Outcomes Research Network. So it's made up of three types of data quality analyses: conformance, completeness, plausibility, and then plausibility is then broken out into 3 types: uniqueness, atemporal, and temporal. So this is just a quick example of the types of checks that we are doing on our pipeline. And this example in particular looks at temporal plausibility. So this graph is showing the arterial O2, arterial oxygen levels, and the means over the course of 4 years. And as you can see, so the labels are pretty similar. One's like PO2 arterial, PO2 arterial OR, and then POC, PO2 arterial. And so you would think that these labels would all be pretty much PO2 arterial. However, looking at the means, they mean different things. And so what we found was that the top line, which has a higher mean, these represent patients in the ICU. So these patients are usually mechanically ventilated, increasing their mean PO2 arterial levels. The middle blue line represents patients who had surgical interventions, and usually those patients undergo general anesthesia, also mechanically ventilated, increasing their PO2 arterial as well. And then the bottom line represents patients on the floor, who usually are not mechanically ventilated. So I think by being able to look at this at the local level, our team is able to delve deeper into these data quality issues, learn more about how our healthcare system stores its data, how that data is represented, and then we can translate that into our work. And we can understand our data better and deliver higher quality data to our researchers. So now, after performing this type of work on our data pipeline, all data quality checks are required for all projects using the data pipeline at DHI. So as we continue to learn about certain healthcare data types and build infrastructure around its utility, it opens up a bunch of opportunities to build meaningful relationships, to heighten the quality of our work, and make a real impact in healthcare for our patients. What started out as a super narrow project for one clinic in POSH ended up flowing into a data science platform for our entire healthcare system with formal processes developed in data quality infrastructure. We hope that by presenting our journey as a group, We can serve as an example for data science integration within a healthcare system. So Mark is now going to talk about Sepsis Watch in the context of building to show value. Thank you very much.
Perfect. So the fact that we're here 3 years later to say we did this successfully is not random. And there's reason why this was about sepsis. So just look at the bottom plot. That's going to show you national average, state average for compliance with evidence-based guidelines for sepsis. All 3 of our hospitals were below average. Our flagship hospital was very well below average. So there was a prior implementation of a best practice advisory based off the news score that failed miserably. So it was firing up to 100 times a day for certain high-risk patients, and it was canceled 86% of the time. So an important takeaway here, too, is that other types of solutions have to fail at solving the problem before people start looking to machine learning and complex technology to implement. Then you need to put together the right team. And this is kind of going back to Katherine's point. This wasn't just one doctor and one statistician. There needed to be kind of a whole network of people around this problem. Not everyone was there on day one, but we gradually put this group together. Another kind of mission, the fact that we're in an academic institution, is also that we always are trying to build capacity. So there were clinical trainees and quantitative sciences trainees kind of distributed throughout this team. You have to engage the right leaders. And part of this is really on the responsibility of the innovation team to kind of have these relationships and have this network of individuals engaged in the projects from the beginning. So the top bullet point, the twice yearly presentations to the C-suite, those are actually standard processes for every innovation project. So every project that gets investment through our team, they have to do mid-year report out and end-year report out to the C-suite, just to make sure that any barriers are removed by senior leadership. We had monthly meetings with the hospital president where we were going live. We had monthly meetings with our health system CTO to make sure that we had the technology that we needed. And then we had weekly meetings. This was leading up to the integration. We had weekly meetings with our CMIO, IT leadership, and actually Epic leadership to do all of the due diligence for how we would be needing to integrate this into the production system. You need to optimize for learning. So it wasn't explicit at day one, but we very quickly learned that we needed to focus on the emergency department initially across all of our 3 hospitals. Here's just another way of visualizing that information. 40% of sepsis in our health system occurs in the ED, and then if you look at the distribution of time of sepsis, the bulk of that distribution is around time 0, which is time of admission. Then you have to build cool tech. You get brilliant people to come in, use things that people are hearing is being applied in other industries. It gets people excited. You start showing how it works. So show how it works for individual patients. As I'm sure you already know, kind of working with clinicians versus technical audiences, different ways of showing model performance conveys different information to different people. So this is an individual patient trajectory showing kind of as the care delivery course continued during the encounter, how the risk score was responding. And ultimately, this ended up being 17 hours before antibiotic administration and 36 hours before clinical documentation of sepsis. And then you also need to show the other outcome measures for the model. So I'm going to switch over now to Will, who's going to talk about how you integrate these into the clinical workflows.
Thank you. Hey there. Green. Thank you very much. So I'm going to start. I'm Will Ratliff. I'm Innovation Program Manager with the Duke Institute for Health Innovation. I'm going to start with a quote from Niccolò Machiavelli about change. There is nothing more difficult to take in hand, more perilous to conduct, or more uncertain in its success than to take the lead in the introduction of a new order of things. And so really that means change is really tough. He goes on to say, Machiavelli goes on to say that there is only lukewarm support for those who lead change And the lukewarmness really comes from the fact that we as human beings don't really believe in something until we've tried it ourselves. And so I think that's, in terms of our build to integrate principle, the main point here is to build that confidence and use that build to show value momentum to really overcome that fear of change. So about a year ago today, I joined DHI. I knew nothing about Sepsis Watch and a very little bit about machine learning, so this weekend has been wonderful for me personally. The state of affairs of Sepsis Watch itself was about 2 years old at that point. It was very thoughtfully built, as Mark had pointed out, but it was not yet real to stakeholders. And so that's where, soon after I joined, I saw an opportunity to jump in and help out. And a quick background on me, so my background is in healthcare IT consulting and some strategy consulting as well, so really saw the opportunity to take the ball and just push it over the finish line through our go live, which you see here. So this is the Sepsis Watch pilot implementation timeline. We went live on November 5th of 2018 for 6 months. We are still live today, thankfully. Just wanted to point out on the left-hand side, your left as well, the chevrons, which really encapsulate the build to integrate principle. The first is to validate the workflow and the app, and I'll jump into that in a second, but really to make it real for those who are using it every day. The next is to educate and train on that workflow validation to really make sure that not only the vision, but those who are going to use the app know the next steps as soon as you wake up, go to the hospital and start using it. Also, the importance of communicating the vision. So for those who are both using the app and those who are supporting the workflow and hospital administrators, et cetera, really important to know that vision and to be able to tell your friend when they ask you about what is Sepsis Watch, what the deal is. I think perhaps the most important thing that we found was to create a governance structure to lead and to give a sense of autonomy to help push that pilot through to its completion. And then also something at the end that we're very excited about and is a little bit preliminary, but is to evaluate performance and to really help show the progress of the team. So to help illustrate the build to integrate principle, I wanted to use the framing actually originally from the Leading Strategic Change. It's a book by Black and Gregerson, which focuses on 3 failures. The first is failure to see, failure to move is the second, and failure to finish is the third. So failure to see, that really stems from that Machiavelli quote that fear of change really prevents the start of the acceptance of the new order of things. So as you'll see on the left, sort of some human kind of organizational and just cultural issues that manifest themselves into those responses, and then a couple of tactics to overcome. But essentially it is, a failure to launch. So the way we overcame the failure to see was really, as you might expect, a process map. And that took the form of a 3-hour meeting with all of the stakeholders that you might think of, so namely the rapid response team nurse, who I'll kind of go through in a second. So those nurse managers, the ED nurse and ED physician managers, as well as our clinical champion, Dr. Kara O'Brien, as well as the CNO and some additional operational leads. But essentially it went like this. I would go up to the board, I would draw the first little box where the RRT nurse swim lane is, and then I would say, well, okay, what do we do next? And just would spark a dialogue as one would typically go through a process map. And so to give a sense of how Sepsis Watch works that we were able to dialogue through, so the RRT nurse first opens up the app and just checks to see if new patients have shown up who are either high risk or are meeting the sepsis criteria. At that point, they call down to the ED, have a quick conversation with the ED physician who still has the authority and the autonomy to diagnose sepsis in real time. If that conversation results in the diagnosis of sepsis, the RRT nurse says, thank you very much. I'm going to help just track bundle completion of that 3-hour bundle on the back end. He or she hangs up and then continues to track completion of the 3-hour sepsis bundle as it's completed in real time. So in terms of overcoming the failure to see, really that manifested taking that workflow and putting it into a Microsoft PowerPoint presentation. So it was not any presentation. It was the Sepsis Watch Complete Guide. This presentation, I would say it's more of a complete deck. Took me about 100 hours to complete. And in a way, I'm glad that Suresh isn't here to hear that, but there was a reason for it. It was a soup to nuts approach of communicating the vision and then the how-to and then the who will support me kind of effort. So starting from the top, it talked about what is Sepsis Watch, what is the problem, why is it my problem, and why is Sepsis Watch the solution to that problem. The next big section, which was of vital importance, I think, was the how-to guide. So whether trivial or not, tried to document every single step as I learned it in real time interacting with the app. And then we got into the Sepsis Watch workflow, which you saw on the previous slide. And then lastly, I think perhaps most important, and you would see a sigh of relief on the faces of the folks that I was training, was the kind of in-depth support that we offered, which I'll get into in just a minute. So here's a look at one of those slides, just in terms of the effort, just to try to make it as comprehensive and yet as easily ingestible as possible. So really went through the steps of trying to make it approachable. The second failure that we overcame was the failure to move. This really focuses on the fact that the vision and the plan is in place, but the next step and the path forward is unclear, or there's a lack of confidence that that next step or path can be achieved. And so the way we overcame that, as you might expect as well, is really just to meet with all of our RRT nurses. So I held about 30 one-on-one training sessions with each of the RRT nurses, which I actually used the how-to guide to train against. So would start actually with this one-pager to communicate the vision. There's a lot going on there, so I don't expect you to read through it all, but it replicates a lot of what Mark talked about with framing the problem and why it's our problem at Duke. So the current, or the then current, sepsis rate bundle compliance in the top left, followed by the setting in which that sepsis criteria through our analysis occurred, compared to the fake news score that we were working with, which was the status quo. And to really, hone in on what the vision was and how we thought that the RRT nurses would help us walk through that vision and make it a reality. So we took all this content and we compiled it, and we actually put it on we also took, we created a Sepsis Watch feedback survey, which I'll go into in just a little bit as well, but the hope there was to collect valuable feedback in real time to then update the app and the workflow per our RRT nurses and our ED physician and nurses' perspectives, knowing that they soon had become the experts in the day-to-day operation and use of the app. So we took all this content and we actually put it on a comprehensive training site for all of our users and those who we were pitching to go access and train. So I would say perhaps the most important thing that we did in terms of build to integrate was to establish the Sepsis Watch Governance Committee. And you see all the members there on the right-hand side. I want to point out there's only two that are in the box, but it's really three. Those are the frontline users of the app and the workflow. And so we found that really after the first meeting in December, those were the users that really knew what was going on, that could communicate the urgency and the relative priority of the problems that they were seeing, such that we could respond to that and help focus our efforts in terms of optimization of both the app and the workflow. So the third failure, which is sort of a misnomer in that it implies that there is a finish line, but it's failure to finish. And really that is the idea that fatigue sets in, the lack of clarity if I'm actually doing anything to move the needle. And so I really go back to status quo, even though I was able to start down the right path. And so one of the points that we found to be very effective and what I'm very proud of is the weekly progress report that we started putting out, which was focused on Sepsis Watch volumes and Sepsis Watch bundle compliance rate as it was coming in week by week. So we were able to leverage that infrastructure that Mark alluded to and that Michael and Marshall are going to talk more about to really give a real-time feedback on how we were doing from a bundle compliance standpoint. So week by week, I would send out this report and try to tailor it as much as possible to the previous week's effort to really make it a personal thing and not just a, hey, here's the report, talk to you next week, good luck. So found this to be very exciting, actually, and so by the end, we had seen really between 50 and 80% compliance range for the most part. Wasn't a big fan of the week of, what was that, like 4-1. But other than that, we had a very successful and rewarding experience through this mechanism. Actually started getting emails from hospital leadership and from the RRT nurses themselves just saying, really appreciate you calling this out. You know, it is giving me the momentum and sort of the inspiration I need to know that there's something that we're doing that is having an impact, even knowing that it is a subset of perhaps what is happening in the hospital. So one more thing is that we took that feedback from the nurses through that Qualtrics survey, and we were able to prioritize and quickly iterate on the updates to the app itself. And I think the main message that conveyed, in addition to the actual help that it gave to our RRT nurses, was that we were listening to them and we wanted their input, and we used that input to make their work easier. And so what you're looking at here is actually an example of the decoupling of the comment and movement functionality on the app, wherein previously you had to, in order to give an update on the patient card, which is what we call them, you had to move the patient to either the screened, monitoring, or treatment tabs in order to kind of leave that status update in the comment field. And so we quickly were able to update that, remove the requirement of the movement to leave an update, and helped them with communication with the other users, and especially during the nurse handoff period. So I'd like to finish with just a quick look at the preliminary bundle compliance results that we've seen thus far, which is, I think, very promising. We're currently working on a more extensive and comprehensive analysis of our performance, but really the in aggregate bundle compliance from 2016 through Q3 of 2018 on average was 28%, and saw that in the fourth quarter of 2018 and the first quarter of 2019, we saw an aggregate 63% Sepsis 1 bundle compliance. So pretty exciting results so far, and we'll be sure to keep everyone updated. And so next up is Marshall and Michael to talk about build to scale.
All right, so we're going to use this, some of the time that we have left, to talk about how we actually brought these models, from research, like you all have been doing, to actually, to the bedside. We want to focus on the tools and sort of the infrastructure that we built so that we can enable, future work. We don't see sepsis as the last thing that we're going to be doing. We really want to make sure that we, again, we scale where we have more capacity. So as Mark mentioned earlier, the number of projects that we've worked on from year to year has grown, very quickly. And our capacity hasn't really kept up. And so we have to try to think about what are some ways that we can increase our capacity to do these types of projects. And so we were sort of brainstorming, and we like to take a lot of inspiration from industry. So we thought, what would industry do here? And so the first thing I thought was we can just outsource this, right? Unfortunately, HR and a few other people didn't really approve of that, so we had to come up with a plan B. How else do we actually increase the capacity? How can we work on more of these projects? And really, plan B is to build tools that work for more than just sepsis, right? Instead of just building something for one particular use case, what are ways that we can build tools that scale beyond projects? So here's sort of a typical project timeline. This was actually put together before we actually, finished the sepsis model. So this is sort of back in 2017 and 2016. And this is a lot of time is spent doing data processing, actually building the model, working on the implementation. And what we realized was, we're spending too much time doing data processing and data cleaning because we do the same thing for every project. And there's been a few talks at this conference that have talked about this very issue. We spend a lot of time working on implementation, getting into the production system. Maybe we can sort of cut that short. And ultimately, the vision would be so that each of our projects looks more like this, right? We're sort of compressing the timeline so that we can, iterate on more projects and essentially be more effective with the same number of people. And also, we want to scale our reach. So we don't want to just build sepsis at one university. We want to, scale this model beyond the walls of Duke. And so we've managed to bring the sepsis model from our main hospital, Duke University Hospital, to Duke Regional and Duke Raleigh as well. And we're currently exploring partnerships with places like NYU and a few other sites as well. And I'm going to bring it over to Marshall now, who runs data engineering at DHI, to talk about how we actually bring these research models and sort of bridge the gap to actual production. So.
Hi, I'm Marshall. I'm data engineering at DHI. I guess I'm the whole department for right this minute, but we're hoping to expand that a little more in the future. So I'm here to sort of fill in the gap here with what we do at DHI. So we use three main tools: Docker primarily, Apache Airflow, and RabbitMQ. These make up the bulk of our infrastructure. So first look at Docker. If you're not familiar, this is like a laptop, but it's a laptop that's built for a very, very specific purpose. So imagine you have a laptop that's only for accessing your email or only for browsing the web, except in my case, I have a Docker container that's only for TensorFlow 1.6 or Postgres 11. These give us control of our environment. These let us really be able to deploy what we need where we need it. It lets us orchestrate really, really well and maintain our system in a way that's both performant and flexible. If Docker is giving us control of our environment, Airflow is giving us control of our code. So Airflow uses these things called directed acyclic graphs. You can think of them as to-do lists for code. These are the things I need to execute at this time to make sure that my model gets run or my data gets extracted and cleaned. These are all codified. They're version controlled. They are monitorable. That's one really nice thing about Apache Airflow is that it keeps metadata about all of our tasks. It keeps performance information, how long did the task take, when was it run, when was it started, was it delayed for any reason. It gives us logs. It gives us control of execution. I can log into the web app and turn things on and off as needed. I can restart tasks that were run a year ago, and they will run exactly as if they were run January 1st, 2018. So for sepsis specifically, we run about 2,000 tasks a day. So these are multiple DAGs. I think it's something like 10 or 15 DAGs that end up spawning 2,000 tasks a day. Fetch and clean tasks run every 5 minutes. These pull from Chronicles, which is the live system behind Epic. We run clinical heuristics every 5 minutes as well. So this is calculating our sepsis definition. We run models every hour, and we do quality control log scans every 24 hours. And then whenever the logs get backed up, we run an extra job to clean them off. So we use Airflow for just about everything. So with hundreds of simultaneous tasks going at any given time, how do we prevent something like this from happening? Right? You've got a bunch of things competing for resources. You've got TensorFlow jobs and extractor jobs. Every hour we spin up, like on the hour, we spin up probably 30 to 60 jobs, depending on the hour of the day. The answer is queues. So we put everything in nice straight lines. We make sure that specific jobs go to specific workers, and we make sure there's no collisions in our performance. So message queues, you could think of this like it's an in-memory task store. So if Airflow throws 60 jobs at our system, this holds them in memory until things can get to them to clean them up. So what's really nice about RabbitMQ is we can assign specific tasks to specific queues. So if I have a TensorFlow job that needs to run, and I have a TensorFlow worker with all the dependencies for that job, then my TensorFlow worker will always get my TensorFlow job, and my data extraction workers will always get their data extraction jobs. It lets us control dependencies from the initiation all the way through execution. So if you put it all together, this is what the back end of Sepsis Watch looks like. So we've got the web app, which is keeping track of the DAGs and setting up the scheduling. Scheduling passes jobs to the task queue. And then workers for the specific queues pick up their respective tasks, write and clean data to the database, models run, write their output to a model database, and that model database serves the web app that is Sepsis Watch. So one really nice thing about this structure is that most of it's reusable. So the only thing that's specific to sepsis is the DAGs and the machine that's running TensorFlow for the sepsis model and the model code itself. So if I want to, say, add a new model, if I've already got a container that's got all of my dependencies in it, all I have to do is add a DAG and add the code for the model. If I need if I need new frameworks or new infrastructure, say I want to do PyTorch, I can just add a new message queue to accept those tasks, add a new worker with the appropriate dependencies, add my code, and turn it on. So this is typically what we do. We add all these things, and then we add a database for the model output, and we're basically done. We're up for trial at least. So we can take things like our 2,000 jobs per day, per day for sepsis, and we can turn that into maybe 2,000 jobs a day for every model as we want to add these out. So I'm going to pass this back to Michael for challenges and implementation.
So I've been told I don't have a lot of time, so actually we got it right on the first try. There were no challenges. All right, that's the end. Okay, no. Just kidding. How do I go back? So one of the big challenges is that research code is not production code, right? So all of you researchers out there who've written code, I'm sure it's super well documented. Everything runs all unit tested. So I don't really need to give this slide, but here's what I see when I see research code. So here, on your left, like that's technically a peanut butter sandwich, but we can sort of argue on how good quality it is. What we'd like to serve is like something on the right. So what we've done is we instituted a policy for code review and to make sure that all the code that we run in production is unit tested, and we run integration tests. And really the main focus on this is that the nurses are the people who are actually consuming the model output. And no matter how many times I look at diagnostics or our team looks at diagnostics, we never see the model as much as the actual end users. They are the ones that are actually interacting with the risk score on a day-to-day basis. They see hundreds and hundreds of risk scores, and they can tell us things about the model that we actually don't know, even though we sort of are co-developers. Also, we try to make sure that we don't have training test skews. So actually, there's a talk about this earlier, but how do we make sure that we encode features the same way, both in the training process as well as the serving process? If we're doing the same thing for labs and medications and demographics all the time, let's try to keep it consistent so we can actually unit test the individual feature creation modules so that next time you want to build a model, you don't have to write your own code to find the maximum value of creatinine within the past 36 hours. It's just built for you. Okay, the other thing is the EHR is not static or clean, as many of you might know. So we've had things happen like certain values have just changed name randomly. This happened with blood cultures, which was very important for our our sepsis model. We actually noticed in production that we had a level of consciousness, sort of variable that somebody decided to just rename, and it just disappeared from our system. So we've built a lot of input monitoring to make sure that that doesn't happen, right? And so a lot of the times, the models that we build will handle imputation, and so it's really hard to diagnose when something like this happens. So we have to build infrastructure. Same things for monitoring the actual system to make sure that we're actually still getting our data. So we have like all these dashboards that help us. There's a lot of other problems which I'll sort of skip over for, we've actually already discussed them today, like entity resolution, unit conversion, things like that. So we also want to keep track of models and their metrics, how well they're working over time. Again, we don't think sepsis is going to be the last model we're going to run. So what we do is we require that every model that we run comes with its own model manifest, which has essentially, the version number of the model, what are the input data requirements, what is the structure of the input data, and we sort of parse these model manifests as we run them to make sure that we keep track of metadata. So we know which model is running, where it's running, what does the performance look like. So we track the metrics, and then we can do sort of like A/B testing in different sites to see how this works. So where this leads us is that we can leverage sort of existing production-ready code to build your features. When you train your model, you can use existing clean data, as Kristen mentioned before. And once you're done fitting the model, you just generate a manifest, you create a container, and then you request a code review. And then as you run, we like to run things in silent mode so we can test to make sure that all of our code is running correctly, that we can sort of track the performance over time, and then we make the results available to the initial clinical pilot team. So we currently have Sepsis Watch in production, and then several of the posters that you've seen today, sort of inpatient mortality, the hyperglycemia, cardiogenic shock, have all used the exact same system, and we're able to sort of scale those out into production very quickly. So I'll sort of wrap up. Really, I want to go back to these three principles. When we were first starting out doing data science at DHI, we realized, like many of you, that machine learning has huge potential in healthcare. And so we really wanted to come back and say, if we're thoughtful about the way that we build these solutions, that we can really prove that to people. So we started by building to show value and working on the right problems. We were hyper-focused on who was actually going to end up using our product so that they didn't really hate it when they were using it. And then we also made sure that we were able to scale this beyond just a single use case and beyond just the walls of Duke. And of course, underlying it all, we wanted to build responsibly. So I'll just end with what our vision is. I think we're all here for the same reason. We all believe in the potential of machine learning in healthcare. We believe that we can build systems and frameworks that enable true innovation in this space. And ultimately, within 5 to 10 years, I hope, and I'm sure that you all hope, that thoughtful machine learning solutions will be ubiquitous throughout the United States and beyond. And that ultimately we can help achieve the triple aim of improving patient experience and outcomes, bettering the health of our populations, and lowering the total cost of care. Thank you.
How y'all doing? Looks like we're about half an hour off schedule right now. Is everyone doing okay? It's an honest question. Everyone doing all right? Everyone awake? Yeah? All right, you guys okay? All right, cool. My name's Lee Hartzell. I'm primarily a clinician, so I appreciate I sympathize with the fatigue. I wish I could give you something, a little stimulant, maybe some coffee later. I don't know. But I just want to talk to you a little bit about our project. I actually presented about this project a couple of years ago. I wanted to give you a bit of a quick update. Really kind of also a transition really from the inpatient setting to the outpatient setting and how machine learning is doing some awesome things. I was talking to Katherine, and she's talking about how, I love MS. I think it's amazing, but I think the things that you guys are doing are just as amazing. It's just really, really cool. So, all right, to get to the point, right? So, here's the problem. Multiple sclerosis, there's more to MS than meets MRI. All too often we use MRI scans in order to make our best judgment about how patients' response to treatments are going, maybe getting a sense of where their symptoms may be coming from, and that sort of thing. But here's the reality, okay? 22 symptoms. At last count, 15 different disease modifiers, 88 symptom modifiers, 4 relapse modifiers, and over 100 environmental features that result in symptom fluctuations that look like this. Every single day. Every day. And here's what we actually get when we talk to our folks. We're patients. We get maybe about a month's worth of information about their symptom fluctuations. And you can imagine that puts us at a massive disadvantage in trying to understand what's going on with multiple sclerosis. We can't characterize a disease that we're not monitoring. And MRI scan is just not doing it. So a couple of years ago, Katherine and I started working on a project where we could try to capture some of this data. And the best way to do that was through a mobile application. It's called MS Mosaic. We released it in October of 2017. It's available nationally through the App Store. It's based on Apple's ResearchKit platform. And here's a quick summary of the kinds of data that we're collecting. There's 2 slides to this. There's a massive amount of data that we're collecting on a day-to-day basis from patients in a variety of different domains, either from the app or from the phone or from paired devices if the person happens to have one. And it goes on here too. So our first objective is, with all these things that are going on, we have to start identifying, can we predict which kinds of symptoms a person is going to start having? But first, a couple of quick slides to kind of give you a sense of a representativeness of, is that the right word? Of the sample. So as of right now, at the last data poll, we've got around a little over 1,700 subjects who've enrolled in the study, who've consented and been contributing data. And the breakdown based on gender is actually comparable to what we see epidemiologically with multiple sclerosis. The mean age is around 30 years. And we've got a pretty decent representation of age since the diagnosis was made and the different types of multiple sclerosis. A lot of folks don't realize that, but there's several forms of MS, the most common being relapsing remitting MS. And here's the data that we've collected from this sample about what percentage of the respondents ever experienced any of the 22 symptoms of multiple sclerosis. And I think that the 2 or maybe 3 most prevalent symptoms are ones that everyone in this room can appreciate right now. Fatigue, cog fog, and mood changes. So But suffice to say, though, from an epidemiologic standpoint, to the best of our knowledge, this is actually in keeping with the most prevalent symptoms that MS patients experience on a regular basis. But can we start to predict which patients are going to have what symptoms? So here is our first effort at that. So with the use of just logistic regression and also a trial with random forests, here are the AUC values for a large variety of the multiple sclerosis symptoms. And we're getting pretty decent values. I mean, we're getting 0.926 with vertigo. One of the more prevalent symptoms, fatigue, of a 0.86. Maybe another way of taking a look at that data. It's a bit choppy because, again, we don't have a massive amount of data, at least not yet. But then the next step really is to say, okay, well, can we identify the patients based on the information that we've collected from those multiple pages ago? Can we predict from the data that we're collecting in the app about which patients are going to experience what symptoms? But we can do that, but we also need to start saying, okay, well, it's not enough to know what symptoms a given MS patient is going to experience. It's also about maybe giving the patients a bit of a heads up. Can we start to predict the timing by which a patient may start experiencing various symptoms? And you see a little bit of that here, okay? So this is just based on some Cox regression models as well as random survival forests. So the AUC values are actually, they're not perfect, they're not great, but they're getting good. So kind of what's the utility of all this? I spend the majority of my time, 80% of my time, seeing patients. And I can tell you that if there's anything that they're looking forward to is someone who can help make sense of what's going on every day. And one of the nice things about this is that we can start to really capture sort of this "you're not alone" feature, this sort of ability to say that, okay, at this particular point in time, with patients who have similar symptoms to yours, 98% of them are having fatigue. You're not alone in that. And it gives me the opportunity to provide patients with anticipatory guidance. Don't be surprised if you start to see these particular symptoms in this particular time frame. But ultimately, it also has the potential ability for augmenting our clinical management. So I mentioned that there's 88 some odd symptom modifiers. With time, because we're also monitoring medication usage, we can actually see whether or not our symptom modifiers are having the desired effects, far better than what we've been able to in the small trials that have occurred before. Now, ultimately, this sort of technology will also enable us to do more enhanced research design for symptom characterization, and also ultimately improve our clinical trial designs. So our next steps. Well, ultimately, we really want to get better at forecasting symptoms for patients, and that's going to require more advanced models, and we hope to be working on those shortly. But we also desperately need to expand the data set. There's about 1 million MSers in the United States. We're currently sampling from around 1,800. Now, the app in and of itself has its own challenges because it's not sticky. And so, oddly enough, I started going to the startup school with Y Combinator back in the Valley, trying to get a better sense of how can we make the app more useful to the patient so that they maintain engagement. We can get the data that we can better serve them in the future. We're also working with a local software developer on the next versions of the app. Ultimately, we also plan on enriching the data set, having folks actually start taking pictures that they feel are sort of capture their experience with a given symptom, and take advantage actually of a social science methodology known as photo voice to process and understand that experience. And then ultimately, of course, we need to get this data at the point of care. And so we're working on ways to expand into a new form that integrates with the medical record systems so that can happen. And that's it. Thanks.